This week on Health Garage.
Acute kidney failure is potentially reversible. Identify the cause, take away the offending organisms or substance, and then the function returns.
Without consent, there can be no organ transplant.
Everyone who has got end-stage kidney disease needs a transplant.
There has been a public outcry in Uganda about the sale of organ and tissues from unwilling donors. And according to the media reports, there have been vulnerable domestic workers who have lost their kidneys and other organs and have also been forced into unnecessary operations. The Uganda Human Organ Donation and Transplant Bill 2021 has established a legal framework for organ sale and tissue transplant in Uganda in order to cater for challenges in healthcare and illegal organ trade. You are welcome yet to another episode. I'm your host, Hope Nyongereza, and we are at the Mulago National Referral Hospital with a doctor here who's going to give us more about organ transplants, and he is going to introduce himself. You are welcome to the show, doctor.
Thank you. My name is Dr. Frank Asimwe Rwabinda. I'm a consultant urologist and transplant surgeon based here in the Mulago National Referral Hospital, which also doubles as Mulago National Specialized Hospital. And I'm glad to be here to talk about transplant. It's one of my pet subjects, and I'm willing to share with you as much as I know.
Thank you so much, doctor. Indeed, you're welcome. So we have heard these terms, organ, transplants, donations. So we just want you to give us a better understanding about the organs, donation, transplantation, and harvesting organs. You can just fill us.
Okay, the body is like a building. A building has got building blocks. So the absolute smallest building block is a cell. It's the one you can compare to a brick. You can replicate that one. Of course, there are ordinary cells and there are specialized cells, but the cell is the most basic of the building blocks. Those building blocks are organized in what we call tissues. That's the next layer. A group of cells which perform the same function, then they become tissues. Then different tissues which again perform an organ, perform a similar function, are grouped together to form an organ which becomes a visible solid, or it could be fluid, part of the body. Now, these organs, they perform specific duties. For instance, a kidney, its work is to filter the waste products from the body. The heart, its work is to pump blood around the whole body. The liver, the pancreas, the cornea, and so on and so forth. So there are different organs. So those are the organs of the body. There are very many. Now, organs do fail, either because of disease or because of injury, or sometimes because of age. They fail. Now, in the olden days, if your organ failed, that was the end of you. You basically wait for your time. But science has advanced that if an organ is discovered to have failed, initially it can be managed to recover. You can manage it to recover its functions. For instance, the kidney. Once you get kidney failure, it is in two stages. There's acute kidney failure, which we now call acute kidney injury. And then there's chronic kidney failure. Then there's what we call end-stage kidney failure. So acute kidney failure is potentially reversible. Identify the cause, take away the offending organisms or substance, and then the function returns. Chronic kidney failure, also potentially reversible. It takes a bit of time, but potentially it can be reversed. But when you have got end-stage kidney failure, it means that kidney can no longer perform its functions. So this organ now in the current era can now be replaced with another organ, another kidney for that matter. And science has advanced such that we can get a new organ from an individual, put it in this person, and then the functions return. Of course, between failure, end-stage failure, and transplant, Now we've got, in the area of kidney failure, we've got what we call dialysis. That is all called replacement therapy. Dialysis basically means the blood will be taken out, literally washed, filtered, and returned. But anyone who has got end-stage kidney failure eventually will need an organ. So that's how the science, that's where the science has reached.
So that takes us to a transplant.
That takes us to transplant. So a transplant is where you get an organ from one donor to the recipient. The donor must be healthy, or at least the organs in that donor should be healthy, and then the recipient has got an organ which is failing. So you remove a healthy organ for purposes of therapy. You put it in the body of a person who has got a failed organ. That is transplant. The other question was harvest. So the process of removing the organ from the donor is called harvest. And you can harvest and store, or you can harvest and transplant. We'll get into the nitty-gritties of that, but there are those two possibilities: harvest, store, then eventually transplant. The ultimate end of harvesting should be to transplant. There are some organs, but mostly tissues and cells, which can be stored before they are transplanted. But most organs, when harvested, should be transplanted within a certain time range, which we'll talk about.
Okay. So, Dr. Frank, you talked about a patient, one needs to be healthy in order to donate an organ. What are the qualifications for someone to be able to donate an organ to a recipient, to another patient?
Number one, you must be willing. Two, you must not be selling, or you must not be forced, or you should not be exchanging it for money. Yes. And those are very, very important. You must be willing. So you must do it out of love and care for the person who is going to receive. That is the most important underlying. Then there should be no exchange of money. You should not give your organs so that you get a favor, commercial or otherwise. Then you must be healthy, and you must be assessed. So you must assess and confirm that you can do without that organ. And not all organs can be donated when someone is still alive. There are some organs which can be harvested and transplanted. So like the kidney, which are two, you can donate one kidney. But then there are those which, if you give, that's the end of you, like the heart. If you donate the heart, you are finished. If you donate the lungs, you are finished. If you donate the pancreas, you are finished. That is why, as we talk a little bit later, we talk about the living donor program. Then we talk about the cadaveric program. Yes, the liver, you can donate the liver, but not the whole liver. In liver transplant, we donate a segment of the liver, and you remain with a big chunk. The donor remains with a big chunk, and then this slice which is put in the recipient has a capability of growing. So you must be willing, no commercial entities. Then you should be assessed to find that you can survive without that extra organ or with that organ. Then you must also be healthy. You must not have a transmittable disease. Basics: malaria, HIV, syphilis, cytomegalovirus, any disease which can go to the recipient. Okay. We'll talk a bit more about that.
Is it at that current time you should be healthy? Because I can have malaria this week, and next week I'm actually going to donate my kidney.
Yeah, we know these diseases are treatable. So treatable diseases should be out of your system. The untreatable diseases like HIV, but we'll talk about the HIV later, because science has gone very far, but we'll build up this slowly. So treatable diseases like malaria should be treated. Treatable diseases like syphilis should be treated. And then you should be disease-free, so that you don't give that disease to the recipient. Then also there is what we call the anatomy, the structure of the organ you're going to give. It should be such that it is normal. You cannot give an abnormal organ. It may be working for you because you are born like that, but it has got some abnormalities. Now, then they are assessed further for those abnormalities. So suffice to say, the willingness, the health, but must also be screened for many, many diseases before that organ is removed and transplanted. So quickly I will underscore that that's why these stories of they have knocked him and removed his organ are not sustainable. Because remember, there's a recipient somewhere. Yes. And if that recipient is probably paying a lot of money, they would want to get a good product. So you knock this person on the road, you don't know what he had, what he smoked, or what he drank, and you rush that organ into this person. Not very sustainable, but we'll probably talk more about that.
Okay, so besides health, does sex and age also matter?
Yes, gender not so much. Gender doesn't matter that much for the organs. Age matters. Of course, the starting point is the age of consent. You must be able to consent, so we don't go for organs.
And what is that age of consent?
Of course, that is legal. We are not reinventing anything. That is legal. Every country has got its legal bottom line. In Uganda, it is 18. You must be 18 and above. In the law which we've just put together, we have also included the aspect of between 18 and 21. Because most adults who are above 18, but still under 21, are still under some degree of parental care. So this 19-year-old, 21-year-old can consent, but the parent should be aware, should give an okay. Now, above 21, you can just go donate your kidney if you are willing, and then you tell your dad, oh, by the way, I've just donated my kidney. So that's the bottom line, 18. Then we prefer to have a donor not older than 45 years. Because beyond 45, you probably need all your organs in your body up and running. Beyond 45 years, you have probably begun picking up some lifestyle diseases, hypertension, diabetes, cholesterol is high. So you might think you are healthy, but the organ you're giving is not quite healthy, so it may not be useful. But it's not very strict. We can move that dial a little bit, because if you have got a child who needs an organ, maybe 20, 40, and a parent who is 50 and is willing to donate, and they are healthy, they've ticked all the boxes with the exception of the one of age, that can be okayed. But strictly 18 to 45, yes. But if you go through the organs that can be transplanted, there are about 11. If you go from top to bottom, the two corneas, not the eyes, the corneas. The cornea is that glassy thing on your eye that can be transplanted. So 2 corneas, okay? The heart, the lungs, the liver, the pancreas, the bone marrow, intestines, skin, all those can be transplanted. Kidney transplant is the one which usually starts, because you've got very many of them, the need is usually much higher, and once you have a kidney transplant program going on, then the other programs are easy to piggy ride on that kidney transplant program, and that's what we'll start with.
How many people need these transplants here in Uganda? Because you see very many people going to India for transplants. Yes. Can you give us some statistics?
Like I said, everyone who has got end-stage kidney disease needs a transplant. So by looking at the people with end-stage kidney disease, that will give you an estimate. Here in Mulago, we've got 25 dialysis machines. They can do 3 sessions per day. So technically, you can do 75 people. But in our statistics, we've got just over 100 people who come for dialysis. Chirudu has got more machines, so they have a number of about 150. Those are already 250. Mbarara, they do dialysis. A few hospitals in town do dialysis. So we've got anything between 300 and 250 persons who are end-stage kidney failure that require transplants. However, not everyone who has got end-stage definitely needs or should be transplanted. There are also some cutoffs. One, you give them an organ. If there are other organs that have failed, you probably may have wasted that organ, that kidney, for instance. They may have heart disease, they may be diabetic, they may be, and their diabetes may be advanced, their heart disease may be so advanced, so they may be unfit otherwise. And you find that even if you give them a kidney, their heart needs to be sorted out. Their diabetes needs, maybe they've got cancer. So not everyone with end-stage kidney disease qualifies. The cutoff for recipients is also at 65 years. Again, that number can move a little bit. But generally speaking, beyond 65 years, the thinking is, of course, if you say how much life do you have, that may look a bit unfair. But you would say, is it fair for me to remove a kidney from a 25-year-old, put it in a 67 or 70-year-old? Is that really fair? Hasn't this person lived their life and we're not disadvantaging this person. So generally speaking, the cutoff is around 65. So anyone with end-stage kidney disease above 65 usually doesn't qualify. With multiple diseases, usually doesn't qualify. With HIV, but we go slow on that one because science has gone around that. So there are some exclusions.
Okay. Yes. There you have it. You have gotten to understand organs, transplantation, donation, and the harvesting of organs.
You're watching Health Garage.
Welcome back from the break. We are into our second segment, and I'm still here with Dr. Frank Asimwe, who is going to tell us the different kinds of donors and the process of how an organ is transplanted from one patient, from rather a donor to a recipient. Yes, doctor.
Thank you very much. Yes, it's good you mentioned the donor is usually not a patient, but the donor can also be a patient. So we've got two types of transplant programs. We've got the living donor program. In the living donor program, the donor is not sick, they are absolutely healthy, they have no reason to be in hospital. Generally speaking, we prefer to have a related donor. Now, why? Because any organ which goes, any cell or tissue or organ which goes into your body initiates an immune response, which eventually results into a possible rejection. For some it is mild, for others it is moderate, for others it's very severe. The less related you are to your recipient, or to your donor for that matter, the higher the rejection, the higher the chance of rejection. The more you're related, the more you are likely to not reject. So a living donor, of course, goes through the process of consent, screening like we've talked about, and then on the appointed day, they both go into the theater, and then they remove the organ and pass it on to the recipient. Suffice to say that the operations begin almost at the same time. So the setting up of the theaters are such that they're next to each other, and the two teams are communicating. So they open the recipient and they open the donor. Now, before the organ is harvested, the team receiving should be ready to receive it, because there's a time limit between which that should take place. Usually we prefer it to be under 1 hour. If you can pull it off under 30 minutes, much better. In the medical language, we call it ischemic time, called ischemic time. From the time blood is stopped from flowing into the organ which is being harvested, then it is removed, it is prepared, then put into the recipient, and then blood is allowed to flow into it. The best would be 30 minutes, 1 hour is very good. Beyond that, the function of the organ you are transplanting begins to deteriorate and becomes less and less functional. So there must be that proximal. So in the living donor program, your donor is with you in the same hospital. You move into the same operation suite with 2 theaters, and that's what happens with the living donor program. Now, there's what we call a deceased donor program. In the deceased donor program, we've got a patient who is brain dead. They got a gunshot, they got a road traffic accident, and they were healthy, and their organs are deemed to be still healthy, and they can be used in a transplant program. We'll roll back a little bit on the issue of consent, because that's very important to understand. In the deceased donor program, before the deceased donor program starts, there has to be a lot of health education. People must be educated. And then persons begin to write in their will that if I die and my organs are still can be used, please use them. This consent is put in their national identity cards, in their passports, in their driving licenses, and it is known, and it's also known by the relatives, that Frank here has said if he dies and his organs are usable, you can use them. So it's not by accident that you are like, by the way, this man's organs can be used. No. So that must first of all be established in the country, in the program, that you have got a pool of people who have said, please take my organs willingly, not exchange of money, you don't have to give anything to my relatives. I've given these organs willingly. That's what is being enshrined in the law. Now, this is the person I'm talking about. So I'll use myself. Having willed that my organ be taken, my wife knows, my children know, if now I get an accident and I'm in an ICU, and the team in the ICU is working all around the clock to save my life, they are as interested in saving my life as any other person is interested in saving someone who's in failure. So they're not being cajoled and conniving with anyone to remove my organs. That must be clear and understood. Also, when someone says, I'm going to donate, the law bars anyone from matching their organs with a potential recipient. That doesn't happen. So on one hand, you've got a list of potential recipients on a recipients list. Maybe there are 100 or 1,000. They have matched them, their blood group, their tissue matches. But there is no one, they are not cross-matched with the potential donors. So when this person's faculties, the brain dies, they are now on life support, they're on a ventilator, they're in the ICU, relatives are coming to see them. If the team in care declares this person brain dead and he had consented, the next step is to inform the transplant committee that we have got such a patient. The transplant committee then sends an independent team of specialists to confirm the brain death. And again, these people who are coming to confirm brain death, they are not involved in the transplant program. They are officially barred from being part of any transplant program. So they come, they look at Frank, and they confirm that yes, Frank's brain has switched off, do not recover. But his heart is still beating, he's on life support, so the heart is pumping the blood is being oxygenated because I'm on life support, I have a ventilator, so the rest of my body is healthy, except the brain. Once these two confirmations have taken place by the two teams, then the transplant council, which is established by government, is now informed that yes, we've confirmed he's brain dead. Now they trigger the harvest. So now they authorize for the harvest of the organs of this person. At that time, the relatives are informed that, by the way, as you're already aware, this person had decreed that their organs can be harvested. And they should have no problem. Once they okay that, then now the typing of the tissues begins. A sample of blood is removed and cross-matched against the 1,000 potential recipients. Once they identify the matches, they say he's matching with person X, person Y, person Z, he's matching with 10. Then there's an automatic criteria to see who of those they have matched with can receive the organ.
What is that criteria they follow?
That criteria is a combination of many things. Sometimes they do, and I'm just giving an example. They go by age, sometimes the youngest. They go by the most healthy, the one who would give more mileage to the organ. Okay? The one who has been on the list longest. Okay? Longest. Of course, they give priority to the hospital where the brain dead person is. So the one who is most affiliated with that hospital, okay? And the combination, it's usually computerized. There's an algorithm which is computerized. So they have to do like 8 or 10 criteria. And they say, okay, out of this criteria, person Y is the benefactor. Remember, like I had said, we already have 11 organs. 2 corneas, 1 heart, 2 lungs, 2 kidneys, 1 liver, a pancreas, bone marrow, and skin. So 11 people will be cross-matched, and those ones can receive. Now, those persons are then notified to move to the transplant centers. This person is still on life support. There is no hurry. It can take a day, it can take 2. Because someone can remain on life support for a week, even for months. So once those persons have moved to the transplant centers, and the transplant centers know, let's for argument's sake, we say, okay, for instance, the heart will go to the patient in Zambia, the lungs will go to the patient in Rubaga, the one kidney will go to the patient in Mbale, another one will go to the patient in Moroto. The transplant center here just requires a pancreas. Once all those patients have moved into those theaters, and the transport systems which are going to transplant these organs are ready, and those transport systems are basically 2. Air, helicopter, or organ transplant ambulances. Let me just finish that one. The organ transport ambulances have a right of way at the same level with the president. So if a kidney is going to move from Mulago to Nsambia, the road from Mulago to Nsambia will be cleared of all traffic. So that means before you build up to a deceased donor program, that collaboration with police should be there. That you just have to tell police that we are going to transplant in Zambia, the organ is coming from Mulago, and they know what to do. The way they tell them, President is going to Nachivubo, and they know what to do. So all those must be in place. Now, once all those are in place, then the person who's going to donate is now moved from the intensive care to the theater, and all these people who are going to receive these organs, including that very same hospital, are already within the hospital. The patient is not opened until the recipients have moved to theater. The transport mechanisms are already, for instance, if it's Mulago, helicopters are already hovering above Mulago. The doctors who are going to transplant are already with their organs, with their coolers, because remember, we want to beat that 1 hour gap. I will pause there.
We see very many people going to India,
yes,
for organ transplants. And the bill was brought up and it was passed in Parliament. So in terms of cost, because we do know that traveling to India and all those costs, it's expensive. Do you think that it will be much affordable now that Uganda is being put at the forefront of actually carrying out organ transplant?
Affordability is relative. Not everyone can afford a KFC. Not everyone can afford a ride in a train. So affordability is relative, but it's going to be cheaper. It's going to be cheaper than it is in India or even Kenya. By the way, Kenya is transplanting. Eldoret here next to us is transplanting. It's going to be cheaper in terms of cost. It's going to be cheaper in terms of the fact that you don't have transport the donor. Your relatives can visit you. It's going to be cheaper in many aspects, but not necessarily affordable, because affordability is one other thing. You know, when you get an organ, you get a second lease to life. Now, a second lease to life should not come easy. It's only God who gives out free things. For instance, I'm on a second lease of life. I had an accident, I blacked out, I didn't die. God gave it to me back for free. But this second lease of life will have to hurt your pocket a little bit, but it will definitely be cheaper.
Okay.
Yes.
So, Dr. Mulago National Referral Hospital was pioneered to be one of the centers, transplant centers. Do you think it has the right facilities and equipment to have these procedures?
Okay, I just want to correct one thing. I was part of the drafting of the bill all the way from 2014, 15 up to the current program, current time. Yes, it had been suggested that Mulago be enshrined in the law as a pioneer, but eventually it has fallen out. We eventually realized that whoever is ready and transplants first automatically becomes a pioneer. That doesn't have to be in the law. However, the issue of Mulago's readiness, yes, we are ready. For instance, we need, in transplant, there are about 4 or 5 things you need. You need an infrastructure, a theater, state-of-the-art theater. That one we have. 2 adjacent theaters, completely cut off from the rest of the hospital, with laminar flow, with intensive care units inside that theater, with HDUs inside that theater. So that one we have, that one can be ticked off. You need human resource, which is skilled. Yes, we've got 2 surgeons who have been training, I'm one of them. We've got nephrologists who have been training, they are around. Pathologists, intensivists. We've got a team, initially it was 15 people, now we're probably about 20 who have been trained. We've not yet finished the training, but yes, we have trained. You need the other support systems, like imaging, laboratory, all those are coming together. Finally, you need a budget. So Mulago is likely to transplant before any other hospital, and as such becomes the pioneer, but that doesn't have to be enshrined in the law. Yes.
So, Doctor, what are the penalties for carrying out illegal organ trade here in Uganda, and will it cross over to the Middle East?
Okay, of course, like I said, there must be consent and there must be no commercialization of the transplant process. So, two things: if the donor has not consented, that is a crime. The doctor performing the procedure will be punished as follows. One, they will be deregistered.
Okay.
If they are first-time offenders, for 10 years. If they are second-time or subsequent offenders, they will be completely knocked off the registration. They will not practice medicine anymore in Uganda. Secondly, they will pay a penalty of, I think, 2 billion and or imprisonment for 20 years or both. Okay. That is the doctor who performs illegal surgery.
Yes.
No consent. The hospital where that surgery has been performed will also be deregistered completely. So that is without consent. If there is commercial, it's a little bit less, but still similar. But if there is exchange of money, then even the recipient, the person who got the organ,
yes,
will be brought in, questioned. If confirmed, they will be penalized. There is a punishment for the person who received the organ. There is a punishment for the one who gave the organ. There is punishment for the doctor who did the surgery. There is punishment for the hospital where that surgery was done, if money exchanged hands. So that is how it stands in the law that is about to be passed. Now, the issue of crime committed outside Uganda's boundaries, that now goes to our relationship with the country where it has happened. Okay, extradition, blah, 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 all those things. But what is in the law, any organization which participates or encourages illegal transplant activities. Again, the illegality is no consent and commercialization. That organization will be deregistered. They will have to pay a fine of, I think, either 5 billion or 50 billion. There is something in the law for that one. So, for instance, if a labor company is proven to have been part of trafficking persons whose organs were eventually removed and with their consent, of course, it has got to go through the law. It has got to go through the courts. It must be proven beyond reasonable doubt. You know how those things roll out. Then those are the punishment. Okay. Yes.
That's all for today's insightful discussion with Dr. Frank Asimwe Rubabinda, consultant urologist and transplant surgeon at Mulago National Referral Hospital. Remember, organ transplantation requires consent, a crucial aspect to consider. Stay tuned for more informative health content from Uganda and beyond. Subscribe to our YouTube channel. Follow us on X and TikTok. Join us next week for another enlightening episode on organ transplant. Keep it Health Garage.
The Health Garage, transforming lives one healthy choice at a time.